Welcome, everybody. I'm delighted to see all of you. We have a really great group. My name is Jean Wyman, and I am co-director in the Powell Center of Women's Health. I'm just delighted to welcome you. I'm also a faculty member of the School of Nursing, and this Women's Interdisciplinary Lecture Series is co-hosted along with the Powell Center by the School of Nursing, the School of Public Health, and the Medical School. So we're all delighted to welcome you here. And we have a really exciting presentation today. So I think that's why we have so many people here. And we are going to have a really short introduction because our speaker wants to allow enough time for all of you to have discussion with her or get all your questions answered. So without further ado, I'm going to do a brief introduction of Dr. Katy Kozhimannil, who is an assistant professor from the Division of Health Policy and Management at our School of Public Health here at the University of Minnesota. And Katy is one of our NIH K-12 Birch Scholars. And for those of you who don't know what Birch stands for, that's Building Interdisciplinary Research Careers in Women's Health. And as you can tell by her topic that she's going to be talking to you on today, it's really apropos because she's going to be talking about how to make birth better, women, communities, researchers, clinicians, and policy makers, how we can all work together. This has been a driving passion of hers, and you will certainly hear that as she talks this morning or this afternoon to you. Her research really applies the tools of health policy and health services research to the field of women's health, with a focus really on the perinatal period. And Dr. Kozhimannil's research really has been making national headlines over the last year or two. And you are probably going to hear stories about why that is from some of the research that she's going to be talking about with us during this presentation. It's really informed the development, implementation, and evaluation of health policy for reproductive age women and families. So without further ado, I'm going to turn it over to Dr. Kozhimannil.
Well, thank you all. Not only do we have a great crowd, but may I say we have a great-looking crowd. So thanks for being here. I'm so delighted to have a chance to talk with all of you about a topic that just makes me joyful. When a mom gives birth with good support and has a great outcome, that is just a wonderful thing. And it's a wonderful thing to me as a person, as a mother, and it's also a wonderful thing to me as a nerdy, data-intensive health policy researcher because it's good for us on a population health level. And so it's where these two worlds collide for me that I'm going to talk with you today about a journey that I have had the opportunity to be a part of with many stakeholders on many different levels of this process, with the best outcome being a happy, healthy, empowered mother and a beautiful, healthy, happy baby at the end. I would like to welcome your questions throughout this conversation. I've really structured this less as a research presentation, although I'll give you a little bit of information about some of the research that we've done, but more, as I said, of a journey from an idea, a concept that has been out in the community for a long time, through the process of research and then into policy and into action in people's lives. And participating in this type of transformation is really what makes my job worth doing. And it's such a privilege to be able to share that with all of you. So my objectives today are to present some of the major population health challenges in maternal and child health. So while I mentioned that the goal is a happy, healthy, empowered mother and a happy, healthy baby, there are many times when we fall short of this, and particularly so in the U.S., and we ought to do better. I'll talk a little bit about potential solutions to these challenges with a focus on continuous labor support from a doula. We'll talk more about that in a minute, but just a show of hands, who knows what a doula is? Oh, this is the best room ever! Yay! That's wonderful. Maybe some of you looked it up when you saw the title, but For those who don't know, a doula is a trained professional who provides support to a mother before, during, and after childbirth. And support comes in the form of informational and educational support, as well as emotional and physical support. Thirdly, I'm going to provide a policy perspective on how innovative ideas can become policy realities. This is a very inspiring story. It really continues to drive me in a lot of what I do. And to describe an example of the process of the implementation of health-related legislation. We're not quite to the implementation phase of this exciting idea yet, but we're starting to get there, and I think that's an area for some discussion as we move forward. I have my pen and my paper, and questions and issues that come up from you around this, I want to hear as well, because this informs my research going forward. Those of you that are here from the community, that are here from the state government, that are providers that are interested in this, I want to know how you see, what the important questions that you see coming out of this, and how my future work can inform those questions and help solve the problems that you may see as we move forward. Okay, so being pregnant and welcoming a baby can be a joyful time in a woman's life, thankfully. However, as a country, we have got some problems. These are the infant mortality rates and rankings for developed countries in the U.S. I know you're not going to be able to read all of the numbers here, but the important point is that the United States, in 2009, in the infant mortality rate, ours was 6.4 out of 1,000. We ranked 27th out of 30 countries, just below Poland and the Slovak Republic, and we rank above only Chile, Turkey, and Mexico. In terms of maternal health outcomes, the U.S. has public health goals that focus on maternal health and well-being, including around maternal mortality. We had high expectations in sort of some of the first rounds of Healthy People 2010. So one of the things that people don't, that isn't often common knowledge, is the fact that maternal mortality in this country is on an increasing trajectory. Maternal mortality in the United States has doubled since the mid-1980s. It has doubled since the mid-1980s. That is incredible, and in a not good way. So we had an expectation, set a goal in the Healthy People 2010 goals of 3.3 deaths per 100,000 live births. Unfortunately, we went in the wrong direction. The reality was 4 times that rate, 12.7 maternal deaths per 100,000 live births in 2007. So, what did we do? We set that target again at a 10% lower. So our target now is 11.4 maternal deaths per 100,000 live births, a 10% improvement. That sure would be nice, but I think we need to do more than just setting goals and not achieving them, and then keep adjusting our goals to have lower expectations. I think that we, as a public health community, need to and can do more about this. One of the other things that's really important is not just looking at average numbers, because the averages here, while they are astonishingly bad and horrifying, they're even worse when we look at issues of disparities, where black women are 3 times more likely to die in childbirth than white women, and this is a statistic that has been unchanged for 20 years. So we need to think about a broader picture, not just what's happening with individual people, but what's happening on a broader societal level that is leading to these kinds of patterns. This is pregnancy-related mortality ratios by race for 2006 to 2009 for the country as a whole, and again, this paints that stark racial and ethnic disparities picture very, very clearly. There are some groups that are not represented here. We have the total and white and black women and other women. There are a lot of women in that category. There's a lot of variability there. You'll notice that these numbers are aggregated across 3 years. Maternal mortality is thankfully a rare event. So sometimes in small subgroups, it's hard to understand how things are changing over time because the outcome of maternal mortality is rare. I would argue, as someone who researches healthcare quality, that we should be thinking about measures of quality that occur well before death. Did you die is not a measure of quality. We should not be doing that. And I think that we need to think more carefully about the steps along the way and what are the positive aspects of quality that we can measure and get more of when we look at childbirth. These are infant, neonatal, and post-neonatal mortality rates, also by race, and here you see a similar issue. We do have a little bit more information across race ethnicity groups here, but the story is one of the rate has not been increasing over about the past 10 years, but it has been stagnating in the United States, so our infant mortality rate is much higher than other countries, as I mentioned earlier, and has not been improving. Furthermore, we have stark, recalcitrant racial and ethnic disparities that have not changed over time. The fact, again, looking at our non-Hispanic Black population, American Indian and Alaska Native populations, and in particular the Puerto Rican ethnic group, we just have some really awful outcomes here that need to be addressed. In addition to the infant mortality rates, I talked a little bit about, so we're going to start to move upstream from death. Like, we're not going to talk about death anymore, okay? Like, let's think a little bit upstream of that. One issue that's going on that's really interesting and important when we think about childbirth and how it's managed sort of from a healthcare systems perspective is the fact that babies are being born sooner. So in 1992, the average gestational age of an American baby was 40 weeks, and a decade later, it was 39 weeks. So that might not sound like a lot, but when you think about this in a population level, when we think about gestation and what it means for, brain development and the physiology of that, the fact that babies are being born sooner could have really broad implications, and we're only starting to understand now some of the issues around gestational age at birth, and there are starting to be more and more protocols around the management of care of pregnancy and the later stages of pregnancy. Gestational age at birth is associated with neonatal outcomes. As I mentioned, this emerging area of research has shown effects on respiratory morbidity, NICU admissions, and in particular a focus on early elective inductions. Birth matters to a lot of people for a lot of different reasons. It matters to us because we were all born. Many of us have children. It's an experience that a lot of people have and share. In addition, policy people care about birth because it's really expensive. Now, that may not be in and of itself a good reason to care, but it's a heck of a good reason when you've got to deal with a budget, as many legislators do and as hospital administrators do all the time. The total cost for childbirth in the United States in 2009 was over $27 billion. It is 7.6% of all inpatient costs. Hospitals they send bills to insurance companies. The total of the bills of those insurance companies is more for maternity and newborn care than for any other whole category condition. So more money than they bill for cardiac care, for cancer care, is billed for maternity and newborn care. In addition to that, we should care about this not only as people who have been born or people that are parents, but we all pay for it. Medicaid funds 48% of all births in the United States. In 2009, we spent $9 billion of taxpayer money on cesarean deliveries. We ought to know that those are performed well and at a high degree of quality and when they are needed. Women that need them should absolutely have them, and women that don't should not be in a situation where there's pressure on them to receive a cesarean delivery. In addition to this, we have a medical system and a medical health insurance system that funds certain aspects of care, the medical aspects of care, but we know that there are broader social determinants of health, and health insurance generally doesn't pay for enhancements in those areas of life that affect health outcomes. Many women cannot afford care if it is not covered by health insurance. I think this is particularly true when it comes to birth, because anyone who has ever been pregnant or had a young child knows how much diapers are. And just like looking down the pike of all the expenses that you have, it feels really difficult for people to spend additional money, especially when resources are limited, on something outside of what's already covered by health insurance. Here's a great graphic that illustrates what I'm talking about in terms of dollar amounts of the cost of having a baby in the United States. This is data from 2013. I show this, and one of my something that's really interesting about this is if we take a comparative perspective here, these numbers are huge. This is really, really expensive, and it has been increasing rapidly. In an interesting international comparison, the royal birth of Princess Kate of Prince George that happened over the summer in July cost about $25,000. It was the most expensive birth in British history. And it's less than the average cesarean delivery in the United States paid for by a private insurer. It was vaginal delivery, not a cesarean delivery, but there was, I mean, it was like pulling out all the stops, get this whole wing of the hospital. What is it about our system that is creating these kinds of incentives that don't likely serve women very well? We're seeing that overall outcomes that don't serve families well, that don't serve babies well, some that often don't serve clinicians well. Sometimes people see these statistics and they point fingers at clinicians or at hospitals or at evil insurance companies. And again, no one's trying to do something awful to anyone. It's just that everyone's working within a system and can only see their own perspective. So it's time to change that system. Are there appropriate solutions? I think there are. And one of those is properly supporting mothers. We already talked about what a doula is. The Donut Doula Organization of North America definition is shown here, and you can see that. And I just want to clarify here that the type of care that a doula provides is non-medical services. So unlike clinically trained providers, physicians, midwives, nurses, and others, a doula provides support in non-medical aspects of labor and delivery. And that's really important. It's really important because, again, these are sort of the broader determinants outside of the medical field that affect health outcomes. We have buckets and buckets of research that show us that that's true. Let's use that research to make a difference in the type of care that women receive and the quality of care they receive. So continuous labor support is associated with positive birth outcomes. There's a lovely Cochrane review of randomized controlled trials that's been updated recently by Ellen Hotnett in 2013 that show that women with continuous labor support have higher rates of spontaneous vaginal birth, lower odds of cesarean delivery, lower rates of epidural use, lower rates of vacuum-assisted delivery, shorter labors, and higher levels of satisfaction. There's a lot of good things that are associated with continuous labor support. An interesting finding that has come out of this field of research is that labor support, those positive effects of labor support are most consistent and strongest when the person providing that support is not a friend or family member and is not an employee or staff member of the hospital. Someone who is professionally trained but is not in either of those two roles, someone like a doula. So it's really pointing to this particular role as being instrumentally important in conferring some of those benefits, and especially so when it can work in conjunction with the medical system to support the medical clinicians in performing their work and the medical care that they're providing to women in labor and in the postpartum period. So what did we do? We saw all of this. It's a good thing. Why isn't everyone doing it? One question we had, and I've had this question for a long time, ever since I had someone to support me when I was giving birth to my children, actually. Why doesn't health insurance pay for this? It's good. It lowers their costs. I know, I read these numbers, I look at medical claims all the time. All of these things equal less money. So one of the reasons that they weren't is because there weren't data that were relevant to decision makers within insurance companies or within public programs as to, how much this would cost. It sounds really scary to add a whole category of coverage benefits, especially for something outside the realm of medical care. Health insurance companies pay for medical care, and so it's a big stretch. The goal of our study was to move this research into the policy realm and to compare childbirth outcomes we specifically looked at diverse Medicaid recipients with support from trained doulas for those from a national population of similar women, so a national population of diverse women with Medicaid coverage for their births. We also tried using the best numbers we could get and tailoring it to the state to the best of our ability, potential cost savings that might be associated with coverage for birth doula care within state Medicaid programs. We wanted to see where that break-even point might be between how much a health insurance company would have to pay for doula support and the lower odds of some of these interventions that I discussed previously, and procedures that are associated with costs as well. We were really limited in how we were able to do this, and there are plenty of limitations to the data that we had into the analysis. I would love to talk about them. I have been talked about in blogs a lot about those things. And again, I welcome that, because that's part of this discussion. We had to use what was available to get the conversation started, and the conversation has been started. So that's that, check, goal accomplished. So what we did is the data that we had were from the Everyday Miracles Doula organization, which is located in Northeast Minneapolis, and some folks are here from Everyday Miracles. Hi. Yay. And the national sample data was hospital discharge data from the nationwide inpatient sample, which is a 20% sample of all hospitals in the United States. So we had just over 1,000 births, doula-supported births among the Minnesota Medicaid recipients, and 280,000 births approximately on the national scale. The outcomes that we looked at were cesarean delivery rates and preterm delivery rates. We really focused on cesarean delivery because we focused on the childbirth-related hospitalization for our cost savings estimates. So that's really what the main focus was. Also, preterm birth is, again, fortunately, a more rare event. So while we did not find results that were statistically significant across the whole population, we found highly suggestive findings, especially for the African American women in this population, that doula support was associated with lower rates of preterm birth. And that's something that we should follow up with more data when we get it. So what we found was that the financial implications to state Medicaid programs of offering reimbursement for birth doulas, we looked at 3 different scenarios. We looked at a 22.3% cesarean rate, which was the rate that was achieved among women with doula-supported births. We looked at a 40% reduction in cesarean delivery rates, which is what the adjusted multivariable model showed was associated with doula support. And we also looked at a more conservative estimate of a 30% rate reduction across the board. So we really tried to model a range of different scenarios to try to inform decision makers. What we found, again, is a cesarean rate of 22.3% among doula-supported births. Nationally, among Medicaid beneficiaries, the rate was 31.5%. Now, we don't know if these women had doulas or not, but we know that very few women do have doulas. Most of them that do are white upper-middle-class women who can afford doula services, with the exception of a few small groups. After controlling for clinical and socio-demographic factors, the odds of cesarean delivery were 40% lower for doula-supported births compared with the national sample. And we found that potential cost savings may be substantial, but really depended a lot on states' reimbursement rates, their birth volume, their current cesarean rates. And another point about this is we weren't setting out to put forward a policy memo as to how Medicaid programs can save money. Last I heard, they're not they spend money. It's what they do. That's, to improve health outcomes. That's their charge. So the idea was not necessarily to find ways to save money, but rather to understand the potential implications at different levels of reimbursement and how that might work in a policy context. Okay. We recommended that states consider conducting internal analyses with their own data. We hoped that our data would provide enough of an impetus to states to look at this internally and consider the logistics of implementation, absorptive capacity, training and human capital, measurement, evaluation, enforcement, and overcoming sociocultural obstacles. I think that's a long list, and that's a list that my mind is turning to now as we look in the Minnesota context as what's coming up with the next steps. Because some people did listen to us, turns out. So this paper was published actually a year and 5 days ago today. It was published on my grandmother's 90th birthday. It was Valentine's Day. It was very exciting. I called my grandma right away. So my grandma had a really difficult delivery with her first child and was hospitalized for a month after the birth. The only way that she survived it was by having emergency obstetrical care at St. Cloud Hospital, where she was transferred after days in labor. And so, I wouldn't be here today if it weren't for emergency obstetrical care, and I know that. And so, just in working with this, and to have this, this paper come out on my grandma's birthday was just incredible. And get to share that with her. It was really neat. Okay, sorry, personal stories. So, So Minnesota, as we will get to, is talking a lot about doula care and how to integrate it into its Medicaid program. However, in 2012, we were preempted by Oregon, the first state to cover doula services through Medicaid. And the way that they've done this is through a non-traditional health worker status. So this includes a variety of different providers of non-medical services. For example, personal care attendants and community health workers who are, like doulas, working in a medical context but are not medically trained or licensed. So again, to try to get around how do you pay for this type of service and regulate and ensure quality, they have a CMS waiver that allows for a 50% federal match, which is consistent with what their Medicaid program gets, and their payment rates are set well below market value. Which has been a problem for the supply of doulas there in terms of their implementation. So their reimbursement rate for support during labor and delivery for a birth doula is around $150, and that is well below. So on average, doula rates range widely, but can average from for a trainee or someone who is early on in their career might be willing to do some services for a discounted rate, between $300 and $500. Some doulas charge up to $1,500 to private clients. So a rate of $150 is well under market value. So what is the process by which we can address this problem with the proposed solution? There are some people here who are in my class or who have taken my class, so this is I really do this all the time, guys. So we had a window of opportunity, as we call it. What happened in Minnesota? In the 2012 election, surprise, the Democrats won majorities in the House and the Senate. I have been involved in a lot of legislative work, and this surprised those of us that were active in this area. We had a Democratic governor, and the first time since the 1970s that both legislative bodies and the governor were under Democratic control. A lot of people saw this as an opportunity to move forward with solutions to issues that had been ongoing, in particular those for which there may be a Democratic-leaning constituency. This issue is actually not one of those. It's a very bipartisan issue, and in every in all legislative discussions that have happened around this, there has been broad support from both Republicans and Democrats, because I think we can all agree that sick moms and babies is a bad idea and supporting them is a good idea. There's questions about how, but frankly, people have been able to come together around this, and that's been great. So secondly was communicating the evidence. So once the politics are set up in a way that makes it actually feasible to address this issue in a policy context, one of the first things that happened was sharing the findings of our analysis with community partners, including the Minnesota Better Birth Coalition, which was a community-based organization working to improve birth for Minnesota mothers. This paper that we all worked on together was accepted for publication on December 21st, 2012, never forget it. And after I called my grandma and everyone I know and hugged my children, and Mary and Debbie, I talked to the journal, because we knew we had been discussing this, that there might be an opportunity to actually move forward legislation. The journal was planning on publishing the paper in November of 2013. And I said to them, we would like to discuss this. Can I discuss this, with the legislative committee? Do I have permission to discuss it before it's published? And they said, well, we really would prefer that you not discuss the results until after it's published. So this is the politics of academics versus reality and policy procedures, right? And I said to them, that's okay, I understand, but this is the information that your journal is about to publish is really important to ongoing policy issues. So is there a way we can work together? And they said, maybe we can publish it sooner. I said, how soon can you publish it? And they said, February 14th. And I said, terrific. So we got that done. And so, in fact, the paper came out on February 14th. 1 week later, on the 21st of last year, was when the bill was introduced in the Minnesota legislature. One of the important pieces, especially to the Minnesota Better Birth Coalition and to members of the community, was the equity message, and getting across not just the issue of cost savings in the legislative context, but also the issue of equity. And this is the fundamental framework that helped raise awareness of equity issues alongside cost issues. Discrimination profoundly affects women's chances of being healthy. Women of color are less likely to go into pregnancy in good health because they are more likely to lack access to healthcare services. So this is sort of putting equity into a broader context and understanding how access to support, access to a doula might help facilitate access to healthcare services, thus better health, coming into pregnancy, during pregnancy, and for many women in the intrapartum period as well. So this is why policymakers should care about discrimination and about childbirth. So building the coalition, so a lot of this work was done by the Minnesota Better Birth Coalition and by Susan Lane, who leads that organization. A number of powerful legislators signed on or sponsored this legislation, including Sandy Pappas, who is the author in the Senate, with key support from Senators Kiffmeyer, Lowry, and Sharon. Again, you can see here these are bipartisan, very strong bipartisan support. In the House, the co-authors were Carolyn Lane and Jim Abler, and with key support from Diane Loeffler, Tina Liebling, and Tom Huntley. And these people were important not just for their willingness to support this, but for their representation on key committees that needed to hear and see this legislation before it was able to move through. In particular, the Health and Finance committees. And there were also academics, clinicians, and payers in managed care that were interested in these questions and issues, all of whom were sort of part of the conversation, sometimes haphazardly, sometimes in a planned way, but getting everyone around the table to discuss these things so no one was surprised is really important. The window of opportunity. So doulas are not a new idea. The idea of women helping women in childbirth is as old as birth itself, but they are an idea whose time has come. And this was really the message that needed to be carried by all of those different voices in order to move things forward. There's a lot of different changes in the policy environment that facilitated this discussion at the time that we had it. So one of the ways to facilitate that, and we're moving back into the policy realm of cost. So this is from an IOM report about the unnecessary services and costs in healthcare, how much is waste. So we're having this big discussion as a country right now around health reform and around efficiency in our healthcare system. So where is that coming from? And what are the levers that we have to address each of these different parts? Well, unnecessary services and prices that are too high, missed prevention opportunities, these all sound like things that are very consistent with what we know to be associated with continuous labor support. So this is really where you can make those connections in a policy relevant way so that people who may not have ever thought of or heard of a doula or known that that could be something that's important really consider it and take it seriously. So in order to understand a value proposition, we need to think about what are the components of value in healthcare. So what it really is the quality and patient experience. And quality can be measured in a lot of different ways. It's a problematic concept, but I think the idea is, we talked about this in my class earlier this week, but the idea is doing the right thing right. So doing the right thing right and patients having a good experience divided by the cost of that can produce value. And aligning payment with value requires measurement of each of these. The momentum is accelerating. The value proposition. Continuous labor support improves outcomes. There's a potential return on taxpayer investment in doula care. That's my lovely yoga teacher, Jessica, who had her beautiful baby Theo in November. So the bill's path. So it was written, as I said, by the senators and representatives listed here. It was announced at the Better Birth rally on January 14th. The paper came out on the 14th, 1 month later, the 14th of February. And the bill was introduced in the House and the Senate under the bill numbers listed here. There was a hearing in the Senate Finance Committee that was instigated by Senator Pappas. And then what happened was it didn't get its own hearing as a bill, but it was included in the Omnibus Health Bill, which is the overarching bill that governs health that is required to move through in a budget year. And that happened in April. There was a Minnesota Council of Health Plans amendment that came up, which was requiring physician supervision and limited choice. And this was where the health plans were worried about issues of quality and issues about sort of the administrative costs of reimbursement if you have this huge network of people and you have to be able to pay anyone, and just, again, a lot of concern, and perhaps they weren't part of the discussion. So this was represented some pushback there. Ultimately, it was not adopted. But it was a good sign about what were issues that do need to be addressed, thinking and moving forward. The bill was later added to the Omnibus Health Bill in conference that was voted on by both the House and the Senate. So it was never heard in committee in the House outside of its inclusion in the Omnibus Health Bill. But at that time and in that committee, where Representative Huntley was leading the conversation, it was incredibly important to have the support of other members of the Finance Committee at that time. So, this is what you can get if you go on the Minnesota State Legislature website, which I would encourage you guys to do if you're interested in legislation. You can actually get the history of when things were heard and where. So you can see the little arrow. That was where the doula bill was added to the Omnibus Health Bill. This is how it moved through. You can click and find out about which legislators are supporting what legislation, what committees they're on, and things like that. So it's not impenetrably difficult to be a part of these things, even in our world of academia where we're not always exposed to it. And it's really important to do so because these are the rules we all live and work by, and so understanding them and understanding how they come to be is really important. So the result was on May 23rd of 2013, Governor Dayton signed the doula bill into law as part of the Omnibus Health Bill. Starting July 1st of this year, the state will allow Medicaid payment for services from a certified doula for pregnant women in Minnesota. The passage of this legislation resulted from more than a decade of work by doulas, mothers, community members, and was led by the Minnesota Better Birth Coalition. And I was so privileged to have had a chance to be a part of it and to play a role in it and to be here to tell you what that story was, because it's not my story, it's a story I got to learn about and be a part of. But I think it's really interesting and inspiring from a women's health, from a public health perspective of how we can work together and we need each other to make changes. So the legislation is passed, is written here. I'm going to move past this because you can look it up on the website if you would like. But I also want to mention the idea. So we're going to start to move now. We had the victory of the legislation passing, but now we'll think about what does that really mean? What does that really mean? When Mary and Debbie, I was talking with them recently, are thinking about taking clients now that are due in July, do they know that that payment mechanism is going to be there and approved so that they can pay the doulas? That's really important to their business to be able to keep doing what they do. And so we need to think about what does that mean. So it said that you can get paid if you're a certified doula. There's actually legislation, there's a statute that says what that means and specifically what certifying organizations are included in that. So there's been some discussion about this list. Is it comprehensive? Do we need to change that? And there is some legislation right now underway to expand that list in order to be more inclusive, especially of training programs that are more culturally tailored and appropriate to that. To different groups of women, including groups of women that may stand to benefit the most from support during labor and delivery. So, it's the hard part. The hard part. Thank you for the courtesy giggle. We have to giggle. Thank you. Okay, so implementation. We had what I think was a really productive and lovely meeting with DHS that was attended. So DHS is the Department of Human Services here in Minnesota. We have the Department of Human Services oversees our medical assistance or Medicaid program, and those are the folks that are tasked with implementing this now. So we got together in a room, and I'm not quite sure how I got wind of this meeting, but it's sort of haphazardly found myself there with the Medicaid medical director, the director of policy for Medicaid, Mary and Debbie, and a bunch of doulas from up north, and we had a range of doulas from different communities here in the Twin Cities, and some actuaries from DHS. Have you guys met actuaries? Do you know who they are? Yeah, what is an actuary? Math geek, kinda. Yeah, they do the numbers. They're number crunchers. They are the ones who figure out like how much how the payments work and how much needs to come in and out and all of that. Really, really, really important for how things run. And I have a soft spot in my heart because I am also a kind of a math geek. I love the numbers. And I depend on people who do the actuary stuff for all the research that I do. So we got this room with like really different people around the table, and we're starting to have this discussion around how should this look. Setting up the payment structure. Did you pay a doula for a whole bundle of services like we pay for prenatal and maternity and postpartum care? Do we pay for the prenatal visits plus the labor and delivery plus a postpartum visit? Or do you pay per visit or per service? Do we need to adjust it for different groups of people that may be more high intensity in terms of their needs? How should that look? What makes sense? And the actuary people are all taking their notes, and I did love the moment when the Medicaid medical director was like, we understand that there's a soul to this. Like, we don't want to take the soul out of this, but we also need to make it work for money. Like, we need to make it work with the money. So it's like necessarily adding numbers to it sort of feels like it's taking the soul out of it, but it takes the soul out of it even more to not pay for it. So we're kind of trying to bring people together to come up with mechanisms for that. It also has to go through a CMS waiver process. And the idea of setting up payment mechanisms. Are they going to be direct payments to individuals, to groups? What are the role of different healthcare entities that like Alina? Do they hire doulas, or do doulas work separately? And right now, a lot of those discussions are still sort of being had, and it's, that part of the process, of the implementation process, is less clear than the legislative process, which has steps that are set out and set forth, and it's a little bit more opaque. So participation in these pieces of the process are a little bit more challenging, and I've certainly had some challenges with that, but I just keep sending friendly emails to people that I know, because everyone's trying hard. It's just we're not all in the same room at the same time, and those answers are urgently needed. Also, different people have different levels of power within this system to ask questions and to get responses to their questions. Communication. So this was sort of more of I previously was talking a little bit more about sort of some supply side issues, but I also think there's demand side issues. Do women know about this? How would they find out about it? Can it be integrated with ongoing initiatives around preconception care, addressing infant and maternal mortality in the U.S.? How will women know how to find a doula? How will doulas know how to bill and use the payment system? How will clinicians know about working with doulas and what their roles are? Are there ways to reach out and ensure that this process is as seamless as possible? And finally, there's really important issues of supply and equity. One of the really unique things about Everyday Miracles and the data that we used in our analysis is they tried really hard to recruit a diverse group of doulas and to match doulas with their clients based on their language, their culture, their background, because birth is cultural. Birth is an inherently cultural process, and when creating that kind of partnership that happens between a doula and a mother, and that kind of match, it really matters to have someone who knows what you're talking about when you talk about something about birth that's important to you. But that's an issue of training. The data that are out, the scant data that are available on the supply of midwives, supply of doulas, midwives, different. Sometimes people get those confused. Both, I love. Different. We have some of both of them here. Raise your hand if you're a doula. Hey, we got some doulas. Raise your hand if you're a midwife. Raise your hand if you're a doula and a midwife. There are some, okay? That's great. Oh, it's so good when there are doulas and midwives. You guys need to talk to me a little bit now, too. I'm going to stop talking soon. But there needs to be training, and there needs to be funding for training. Certification and quality control are important. Diversity in terms of racial ethnic diversity, language diversity, and geographic diversity. One of the challenges is training doulas who don't speak English as a first language. They can be incredibly important advocates for supporting women, but if the trainings are not in a language that they use, then it's not going to be accessible to them. Reducing disparities in underserved communities, there are a number of projects that are sort of focusing on particular communities, and there may need to be additional mechanisms and additional legislative support for demonstration projects that would require more infrastructure to be built in rural geographic areas among communities that are not part of the sort of mainstream healthcare system. And so I think that there are going to be some obstacles, but I also hope opportunities along the way to implementing this. That is the last that I have. I have a lot of people to acknowledge, many of whom are actually here.
Yay!
And again, I'm really privileged to be able to talk with you about this journey, and I would love to talk a little bit about some of the issues related to implementation, or take any questions that you have about this project or the research that we're doing. Feel free to send me your research questions, and I will try to work on them as I can. Thank you. Are there any questions or comments at all? Yeah, Rebecca.
So, this is great to hear it all put together like this. So the implementation piece, now that you have your foot very much in the door, do you feel like they will, there will be opportunities for you to constantly sort of assess what's happening with implementation, and then perhaps be able to alter the course of how it goes? Because it seems like so often, at least in my field, the advisory capacity often happens after the fact, and it's too late to change what's already sort of spun down the road. Do you feel like you may have room that there could be an iterative process for the implementation?
Yeah, I really hope so. It's not the traditional way of doing things. There really isn't a pathway for that, either from the side of the of DHS, who, I mean, when I've talked to them, they will take my calls and meet with me and stuff, but I have to keep, because I'm not, like, they don't have a, call Katy button on their, every few months to check in about this. And they're not used to having someone from the outside being a part of their discussions. Unless I have funded time for my research to pay for that, I'm not really doing that as part of, beyond sort of general service things. So it's difficult because it's in neither of our job descriptions, but we understand that it's important. And so I do think there's a foot in the door thing, and I do think that there's an openness. But I think that's a sort of central challenge of doing community engaged work and legislatively engaged work in an academic context, and I think that's really hard. I do think there are opportunities, and one way for that is to advocate for legislation that requires accountability measurement or reporting. So if the legislature requires that DHS evaluate the implementation of this, then and provide some resources for that, then the state can put out a call and hire someone to do that evaluation, and that sort of meets all of those needs. And so that's actually one of the things that I would love to see happen and would love to help with, because I think that helps keep us all accountable. This is our taxpayer money. We want to know that it's being spent well. We want to see that it's reaching the people that need to. But it's challenging to do so. Thanks for your question. Any other questions or comments? Anything? Yes?
What is the legislation that these groups will be working on going forward?
So I don't know what all the things that are going on right now. Maybe some folks here do. I know that there's some legislation focused on, as I said, the certification of doulas and expanding the definition of what constitutes a certified doula. I know that there are legislative efforts that are being discussed to support particularly high-risk women, including women with substance use disorders, and incarcerated women and families, and addressing the particular needs of women that are more vulnerable. And there are good data showing that for those women, when they experience a positive and empowering birth experience, that can change their ability to be a parent, to interact in the world, and if somebody believes in them, they can have it be a turning around point. So again, like I'm saying, there's good evidence. It's hard to measure empowerment, but there certainly is good evidence of change in the trajectory for people that are previously in a difficult situation. So yeah, Kristen.
Hey.
Hi.
There's also legislation this year for maternity leave, and I know right now it's limited to a certain scope of women, and but if you think of what other countries are doing and what the chances they're getting to start that good bonding with their babies, I mean, last year this legislation was introduced for pay for maternity leave, and it was sort of laughable almost last year, even just last year. And this year, with all the new momentum and all the new thinking about doulas and more integrated care teams, this bill actually has a chance at least to be heard this year, which is progress. So.
Yeah. And I would be remiss to say, this, like, how quickly this happened, things don't usually happen this quickly. And also, again, this is the result of 10 years of work and dedication. So sometimes getting a hearing is the first step. Like, it builds on itself over time. Again, I got involved in, like, the very last chapter of this journey. But I think it speaks to the importance of persistence and of collaboration and working together across silos and across divisions in this work. Yeah, Debbie.
We just have to say, we I think, groups of doulas believe that without what you did, it wouldn't have happened. So,
well, thank you.
Thank you, Katy.
Thanks. Yeah, Kelsey.
So you touched on this, or at least alluded to a little bit, when you're talking about the things that you're doing in terms of stepping in and activity and going and spending your time with the state. You're not grant funded to do that, nor are you really rewarded necessarily in the tenure evaluation.
There is it's certainly recognized within service.
Oh, it is.
But it absolutely recognized within service. So the tenure criteria are research, teaching, and service, and absolutely engagement with policymaking is a very important part of. I don't mean to discount that at all, but the majority of the criteria are under research areas, or those are the criteria that tend to be weighted more than others. And it's sort of like once you've been engaged and sort of met the bar with respect to service, additional engagement isn't going to buy you like a super over the top, tenure criteria. So, and again, I'm not trying to say like, oh, I'm worried about that or anything. It's an incentive, it's a structural incentive in the system that makes some of these partnerships somewhat difficult. So one of the other things is what I mentioned earlier, with respect to publication. Right? Like you can't, once I published, or once the paper was accepted, I couldn't talk about it with the legislature because of the, restrictions on that side of things. But you had a question.
Yeah,
Sorry.
so do you see that structure, those structural incentives changing, whether it's here or if it's just sort of something that's being acknowledged?
Yeah. We actually had a discussion about this recently at a seminar for junior faculty about this issue of as the university moves toward community-engaged research, how is that recognized in the process? And that's an active dialogue, and I know there are people here that are on APT committees and that do make these decisions and are leaders in our university, and I think there's really an openness to that. One example is at George Washington University, where in their health policy department, they actually changed their tenure criteria to a public health practice, so that you do have to. Obviously, getting tenure in an academic institution is about being a scholar, but in their public health practice section, they're also recognizing the role of engaged scholarship that may not show up in the like it may be a report to CMS, or it may be something that one would do for a state legislature, or something that's more that's not an academic, not considered a solely academic product, but is counting toward tenure and toward scholarly production for individuals who work in those fields. So I think there is some change there, but that's it will be with time. And I as an untenured faculty member, probably am not going to be making those changes right now, but hopefully I will move through and have a chance to give voice to that. But again, there's a lot of openness to that possibility and a recognition of that. So, yes.
I just had a comment and a question. I think this is really exciting, and a year ago I sat in I do some advocacy work for CAM therapies, and doula services is kind of considered complementary, an alternative kind of treatment or therapy or service. And so I happened to coincidentally be in the Senate meeting where it was passed, and just to actually hear legislators talk about long-term cost savings versus short-term budget cuts, in these sections. So it was really exciting to see that passed. There is some current legislation in this session that I know about that relates to allowing for licensed practitioners to practice camp and give referrals, because there's a lot of intimidation from the different boards and so forth. So just to share with you, hopefully that will be positive for doula services and other things.
Yeah.
And then my question was on the certification. It sounds like you were really actively involved in different areas and aspects of this whole legislation, just in the context of either certification or registration or licensing. Is the certification under health board or particular?
So I actually don't know a lot about the specific aspects of the certification process and how that's going to need to happen. Do you guys know about this right now? And this is where there's going to be that certification fee to be registered with the state, and you need to provide documentation that you're certified under one of the things that was mentioned above. And that's one of the other things that we've been discussing. There's a $136 fee to get registered with the state as a doula, and I mean, again, that doesn't sound like a lot, but it starts adding up, and especially if you've had to get trained, and that could be thousands of dollars. I mean, that's really, you're starting off at a underwater, and that's a tough way to start off, especially if depending on what the reimbursement package looks like, and ensuring that this is a viable career option for people that want to enter it. Thank you all so very much. It looks like we've come to the end.
Well, I want to thank Katy. That was just an outstanding presentation. You can really see her passion for improving the health of reproductive women and changing health policy so that can be possible through her research. So a wonderful example of how research can change policy. I want to invite all of you, before you leave, to our next presentation, which is coming up pretty quickly. It's on March 5th, and we're very fortunate to have a visiting scholar here through the Fessler Lambert Chair in Aging Down Low is bringing to us Miriam Nelson. Some of you may know who she is. She's the director of the John Hancock Research Center on Physical Activity, Nutrition, and Obesity Prevention. And she's going to talk about Strong Women, Change Yourself, Change the World. She's published a book, Strong Women. I can't remember the other part of it, but I think it'll be a really interesting presentation. So please join us on March 5th. And don't forget to fill out your evaluation form and turn it in at the back. So thank you again for joining us today.